Hi everyone, Dr. Kofi here again, and welcome to my YouTube channel, TutorMed, where everything medicine is simplified. In today's video, we will have some tutorials in internal medicine, and basically, we will be discussing clinical case scenarios. And so if you are preparing for any licensure exam, kindly ensure to watch this video to the end because this is just for you. And you might want to consider subscribing and putting your notification on if you are new here. Okay, let's begin. Very good. And so let's look at our clinical case. We have a known type 2 DM patient with a BP of 180 over 110 millimeters of mercury who was brought to your consulting room with pedal edema, proteinuria, and oliguria for 2 months. The first question is, what is the most likely diagnosis? Let me give you some time to think through this case. Very well. Now, one of the helpful things to do when answering clinical cases is to identify relevant information in the clinical stem. And so in this clinical stem, the relevant information are the fact that the patient is a type 2 diabetes mellitus patient, the fact that the patient came with a BP of 180 over 110, came with pedal edema, proteinuria, and oliguria for 2 months. And so, depending or based on these relevant information, what do you think the diagnosis most likely is? Now, when writing a diagnosis, it is important to write a complete diagnosis to score the 4 marks. And so for this question, the diagnosis is acute on chronic kidney disease, secondary to diabetic nephropathy, complicated by hypertension. We will explain how we came by this diagnosis, but kindly note the completeness of the diagnosis. Note that the diagnosis explains all the relevant information in the clinical question. And so for this question, we are going to assume our patient is a male patient, although the question didn't give us the sex of our patient. Now let's explain how we arrived at the diagnosis. The first is that the patient has a chronic medical condition, which is type 2 diabetes mellitus. And then we are told that he came with pedal edema. Now please note that whenever a patient comes with edema, it could be that he has a problem with one of the following 3 organs, either the heart, the liver, or the kidney. Now, edema of cardiac or heart origin usually begins with dependent areas like the legs and then spreads to other parts of the body. And then edema of kidney origin or renal origin begins with the face and later involves other parts of the body. Edema of liver origin begins with the abdomen and then involves other parts of the body. And so for this patient's pedal edema, the likely causes are 1. Congestive cardiac failure, 2. Chronic kidney disease, 3. Acute kidney injury, and then 4. Decompensated liver cirrhosis. Again, we are told that he had proteinuria, which means protein in urine. Now, the urine dipstick we use during urinalysis is able to selectively detect albumin in urine, and so dipstick proteinuria is almost always albuminuria. And so once you find albuminuria, the most likely cause or the most common cause of albuminuria is glomerular damage. And so albuminuria is an evidence of kidney damage. And so the pedal edema plus the proteinuria makes kidney pathology high on the list. And so as mentioned earlier, the kidney pathology may be acute or chronic. And so we can have acute kidney injury and then chronic kidney disease. However, the proteinuria speaks more for a chronic kidney disease than it speaks for acute kidney injury. And so at this point, it is suspected that the patient has a chronic kidney disease. And then again, we are told he had a BP of 180/110. Now, a systolic blood pressure of 180 or more is severe hypertension. Now, when a patient has heart failure, typically he would have hypotension, not hypertension, meaning a failing heart usually cannot mount that kind of high BP. And so, again, this makes congestive cardiac failure very unlikely in this patient. Now, please remember that when someone has hypertension, the hypertension can either be primary or a secondary hypertension. The difference is that in secondary hypertension, there is an underlying cause, while in primary hypertension, there is no apparent cause. Of all the secondary causes, renal pathologies are the most common cause of secondary hypertension. And so it is likely that this patient's hypertension is from a kidney problem. And so at this point, the suspicion is that the patient has a chronic kidney disease, which is complicated by hypertension. And then we are told he has oliguria for 2 months. Now, oliguria simply means decreased urine output. How do we tell whether the patient has oliguria or not? The patient might give you a subjective complaint that he has peed a little the whole day, but objectively, oliguria is urine output less than 500 ml per day, and so you pass a catheter and then you monitor the urine output over 24 hours, and if it's less than 500 ml, then you can objectively say the patient has oliguria. But the question says the patient has oliguria. Now, usually, CKD patients typically will have a preserved urine output, meaning it is very rare or unusual for a CKD patient to have oliguria. And so, what kidney pathology results in oliguria? It usually results from an acute process. And so, oliguria, is usually from acute kidney injury. Or another scenario is that the patient can have a CKD, and then with his CKD, he develops an acute injury on his chronically diseased kidney, what is known as acute injury superimposed on a CKD. In other words, the patient has an acute on chronic kidney disease. And in a CKD patient, one of the most common causes of a superimposed acute injury is UTI. And so UTI can cause acute on chronic kidney disease in a patient who already has CKD. And so you understand why the diagnosis became an acute on chronic kidney disease, right? Very good. Very good. And so please do not forget to like and share this video and support us by subscribing to the channel. Now let's use this slide to say something little about chronic kidney disease. Chronic kidney disease is a long-standing progressive decline of kidney function or deterioration of kidney function occurring for at least 3 months. What this means is that if the kidney starts declining in function and this decline occurs over at least 3 months, then you can say the patient has chronic kidney disease. Common causes include diabetic kidney disease, which is known as diabetic nephropathy. And so we have diabetes causing the kidney disease. And then the second common cause, we have hypertensive kidney disease, known as hypertensive nephropathy. And then we have other primary or secondary glomerulopathies, meaning disease of the glomerulus. But by far, the two most common causes of CKD are diabetic nephropathy and then hypertensive nephropathy. Now, in the question, the patient is known to have type 2 diabetes mellitus, but the severe hypertension was found on presentation, meaning the diabetes, has been with the patient longer than the hypertension. And so between the two, the diabetes is the likely cause of the patient's CKD, and the hypertension rather is a complication. Now, one interesting fact is that Most patients with type 2 diabetes mellitus are diagnosed late because, unlike them, the type 2 diabetes patients, the type 1s present with the symptoms of diabetes very early, and so the diabetes in type 1 is recognized early compared to the type 2s. And so because the type 2 diabetic patients often present years before they are recognized, the kidney injury or the nephropathy often develops less than 10 years after the diagnosis of the diabetes. In other words, by the time you diagnose a patient with type 2 diabetes mellitus, the hyperglycemia would have already begun its harmful effects on the kidneys. And so within just 10 years of diagnosis, the kidneys become diseased from DM. And so back to our question 1. What is the most likely diagnosis? The diagnosis is acute on chronic kidney disease, which is secondary to diabetic nephropathy and which has been complicated by secondary hypertension. Now question B says, what 3 investigations will you carry out? Now you've been asked to give only 3 investigations, and so please ensure you give just 3 answers. Avoid giving more than the number that has been asked by the question, because the penalty is that the wrong answers will be selected and then marked, and then you would lose some points. And so here, the trick is that you think about your diagnosis. You write diagnostic investigations first. And so the diagnosis is kidney disease. I mean, it has something to do with the kidney. And so which investigation should we write first? Yes, you are right. We should write blood, urea, electrolytes, and creatinine, because the creatinine will tell us whether the renal function is reduced or not. And even apart from the creatinine, the electrolytes, the potassium level can go high, or there can be hyperkalemia, which is also a complication of CKD. The next investigation to write is abdominal ultrasound scan, and you are doing the scan to look for sonographic features of CKD, which includes a reduced kidney size, a poor corticosinus differentiation, and then echogenic kidneys. But please note that diabetic nephropathy usually does not cause a reduced kidney size. It might even give you an enlarged kidney size. And so the reduced kidney size is not typical for diabetic nephropathy, which this patient has. Then we can do routine urine exam for blood, because hematuria is also an evidence of kidney damage. And then the routine urine exam might give us findings suggesting a UTI, which can explain the acute on chronic picture. The urine RE again can show us casts. If there are broad casts, it can tell us that maybe the kidney disease is advanced. So we've mentioned 3, but other important investigations include a full blood count, which might show a normocytic normochromic anemia, which is also a complication of the CKD. Then we can do serum calcium and phosphate levels, which may show hypocalcemia and then hyperphosphatemia. Then we can also do a glycated hemoglobin, HbA1c, to know the extent of the glycemic control, whether it is bad or it is within control. Now, there was a third question which said, what will be the long-term management of this patient? Now, remember the principles of management we've been using. We said the first thing to do is to identify any reversible underlying cause and then treat it. Then next, you manage the symptoms of the disease. And then next, you anticipate complications of the disease and then prevent them. However, if the complications have occurred, you manage them. Like the hypertension, it has already occurred, and so you manage them. And so here, the underlying cause is the diabetic nephropathy. It is from DM. And so what we do is that we control the sugar. And so for the sugar control, you control with appropriate anti-diabetic medications. I used appropriate because, for example, you cannot give metformin in a patient whose EGFR is less than 30. You might want to consider insulin, but again, you have to be cautious with the insulin because for a CKD patient, too much insulin can cause hypoglycemia, and so I said appropriate anti-diabetic medications to control the sugar. And then the next is BP control. We are with the complications right now, and so BP control, you control the blood pressure with appropriate antihypertensives. And then typically here, the antihypertensives we use include ACE inhibitors like lisinopril, and then or angiotensin receptor blockers like losartan. Now, these should not be given together, they should be given individually. They help improve proteinuria, and then they may slow down the progression of the chronic kidney disease. But these drugs are potassium-containing drugs, and so they can only be started when the patient hasn't got hyperkalemia. Remember, hyperkalemia is one of the complications of chronic kidney disease. And then we can also give calcium channel blockers like amlodipine. Amlodipine has been shown to improve the GFR. Now, in managing the blood pressure, for patients with diabetic nephropathy, the BP target is around 130 systolic over 80 diastolic or less. And then while doing all these, we can be monitoring the serum creatinine to see if the renal function is improving, and then we can be doing regular urine REs to see if the proteinuria is resolving. Now, still on the long-term management of the CKD, one of the kidney functions is to excrete acids. And so when the kidneys are diseased, these acids build up in the body, and then they may cause metabolic acidosis. And so metabolic acidosis is one of the complications of CKD. And for the metabolic acidosis, we can give sodium bicarbonate tablets. Then another complication is hyperphosphatemia. And so for the hyperphosphatemia, we can give calcium binding drugs like calcium carbonate. So calcium carbonate can be given for the hyperphosphatemia. And then we counsel the patient on lifestyle modification measures, like the patient should decrease the amount of salt he takes, the patient should avoid foods with high glycemic indices, which might worsen the diabetes. The patient should avoid smoking, the patient should be eating fruits, vegetables, avoid alcohol, etc. And then lastly, we counsel the patient to go to a nephrologist, so a nephrologist referral for renal replacement therapy, which can either be hemodialysis, or after the nephrologist has assessed the patient, the nephrologist can recommend renal transplant ultimately for the patient. And so the last question says, mention 4 complications of the condition. And I think we've mentioned several of the complications passively in our discussions, but we will still list them again. But more importantly, please ensure you just write 4 complications. Do not go beyond 4 because of the penalty I discussed earlier. And so one of the complications is anemia, which is typically normocytic normochromic. Another is hyperkalemia. Then we can have metabolic acidosis. You can have acute pulmonary edema from the fluid overload. Remember, the kidney is responsible for regulating the fluid amount in the body. And so the overload causes the edema and can cause pulmonary edema as well. And then you can have secondary hypertension, like we mentioned earlier. You can have renal bone disease, which is known as renal osteodystrophy. Then you can have hypocalcemia, hyperphosphatemia. And so this is where the question ends. And thank you for watching. Kindly support us by liking and then sharing our videos, and then subscribing to our channel. So see you next time with more tutorial questions. And the next is a tutorial in surgery. Thanks for watching once again. Bye. you.